stream is started, please. Yep. Okay. I'd like to welcome you to this meeting of the Health and Wellbeing Board being held on Monday the 13th of July. For fire and emergency evacuation, for those present in the meeting room, if the fire alarm sounds, please leave the building by the nearest exit and make your way to the fire assembly point in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council website, YouTube channel, and is making a recording. Others are permitted to film, photograph and record public meetings, providing that they do not disrupt the business of the meeting. For participants in the room, please raise your hand to indicate that you wish to contribute. When invited to speak, press the button on the right of the microphone unit and speak directly towards the microphone. Please remember to turn your microphone off once you've finished speaking. Please ensure, and I've not done that, please ensure that your mobile phones are switched off, other devices as well. For participants in attendance remotely, can I request that you use the raise the hand feature within the system if you wish to contribute and to introduce yourself when called upon. Please note that only board members present in the meeting room can vote. So, are there any apologies for absence?
Yes, Chair. We've received apologies from Sue Harris of Herefordshire and Worcestershire Health and Care NHS Trust, John Hobbs, Herefordshire Council, Tina Russell, Herefordshire Council, and Dr. Lauren Parry, Herefordshire General Practice, may join remotely later in the meeting.
Right. Any name substitutes?
Yes, Chair, thank you. The following subjects have been identified. Naomi Keeling for Sue Harris, and Naomi's joined us remotely. Liz Farr's present in person for Tina Russell. And also note that board members Superintendent Gareth Morgan and Sarah Shingler have joined the meeting remotely. So as you mentioned,
Sarah Shingler's remote as well.
Indeed. So
right,
both can participate at your discretion, but not vote.
Right, just make sure my phone's not going to go off at any minute now. Are there any declarations of interest? No? Okay. Item 4 is the minutes. To approve and sign the minutes of the meeting held on the 18th of May 2026, pages 9 to 16. Does anybody have any problem with the minutes? Do I have a proposer for the minutes? Seconder? All in favour? Thank you. We now move on to item 5, which is questions from members of the public. There are no questions from members of the public. Item 6 is questions from councillors. There are no councillors who've submitted questions. Item 7 is the Neighbourhood Health Update. To provide a summary update on a neighbourhood health progress in Herefordshire. Okay. And I think Nigel Fraser's online.
Yes, that's okay. Can you hear me okay?
Yes, we can hear you.
Shall I crack on?
Yes, please.
Thank you. So, Ben, I wonder if we could have the first slide, please. So, this picture will be familiar to us all. I think the things from a neighbourhood health perspective is that we are older and we're getting older quicker than the rest of England. And of course, our geographical disbursement, if you think of the population of Worcestershire being 3 times the size of Herefordshire, you can see some of the issues which influence some of our neighbourhood health delivery. Next slide, please, Ben. So this is the governance wiring diagram for neighbourhood health. You can see that the Wye Valley Trust is the host provider and provides the governance. You'll see central to this is the partnership board, where all partner organisations will make decisions relating to neighbourhood health and other partnership issues. The Neighbourhood Health Delivery Board reports into that and also reports back to this board, as I'm doing now, and that's chaired by myself, and that is really a delivery board to make sure that we are delivering the neighbourhood health services that we need. I think there's probably, you can see there are some subcommittees, but all part of that Wye Valley Trust overall governance. Next slide, please. Okay, so we were selected, as you will be aware, to be one of the 43 sites for the National Neighbourhood Health Improvement Programme, and we got together with all partners and we produced this vision statement. As this was signed off by everybody, and it was great to see such a broad breadth of voluntary and community providers there too. So that's together we're creating a Herefordshire that is the best place to grow up, thrive, grow older and die well, enabled by integrated neighbourhood teams, empowered communities where the person's goals or needs are prioritised. We thought that captured what we were trying to do, and the key enablers are in those green boxes that we thought were the so that's really the sort of vision statement that we collectively own. Beneath that on this slide is just a little bit of a touch on the general practice organisation, which has reorganised slightly over the last year, and we're probably quite unique in that we have a single strategic board for general practice. Quite often they have different functions split between LMC, GP federations and clinical directions at Neighbourhood. We've brought that all together in Herefordshire, which enables general practice to be a good partner in neighbourhood health delivery. So we talk about 3 tiers: practice, neighbourhood, and then at scale, all working together through the strategic collaborative board. Next slide, please. So what's the model of care? So really we're looking at a continuum here between proactive care through interventions and back to recovery at home. What the aim here is to do a lot more planning, a lot more care planning, but also put in a lot of more support earlier so that actually we can avoid the crisis and that inevitable ambulance to hospital. So having done the planning, having done the assessments, and this primarily looking at the highest risk patients in the first instance, we are then able to create cohorts of those higher risk patients, plan services around them. And then if things do happen, then there is that MDT, multidisciplinary team response coordinated through the single point of access. And we're quite excited that hopefully in a few months we will be moving to 24/7 single point of access. So that's full care coordination 24/7 as opposed to 8 to 8, including all the response from community services as well. So that's quite a step up, but that's such a key bit to making sure that people get the care they need, but they can have it not necessarily always in a hospital. And then there will be times when the right thing is to get people into hospital. What we're doing is hoping to just really support those who don't need to go to hospital care in a different location. And to put it into perspective, if we were to reduce those admissions by 5 a day, we would get rid of corridor care in our hospital. So that's the challenge that we have, but it's not a simple silver bullet solution. What we're doing here is having to do a lot of care planning, a lot of support, a lot of prevention, and a lot of alternative services to keep that safe and better. Okay, next slide, please. So there is currently a national neighbourhood health centre estates programme, and we've put in a bid. A lot of detail in here. apologise for that. But essentially, our bid is a hub and spoke model because of our rural disbursement, with Nelson House in the city of Hereford, which is our hub, and our spokes going out to each of our neighbourhoods. I guess the challenge for us here is to make sure that that's starting to align with the pride of place investment, so that we can get the health component and the social component working together. Next slide, please. So this is just a little bit on Nelson House. Those who have used the GP out of hours service will be familiar with it. It's just had some more work done on it, so we've just had more clinical rooms and some therapy rooms added, which is good innovation. But possibly you wouldn't be aware of all the services that operate out of it, as well as the GP out of hours. We've got things like cataract surgery. We've got our outreach programs for prevention. We've got our new ADHD diagnostic service. We've got Talk Wellbeing with the NHS health checks, etc. There's a full list there, but for your information. Next slide, please. Okay, so this is a little bit of a complex slide. The general practice component of neighbourhood health is contracted by the ICB, and that falls into two parts of a contract. One is about that proactive care that we were talking about, and the other is prevention in priority neighbourhoods, so those areas of most deprivation. So each neighbourhood, each primary care network is putting together their proactive care planning, their respect forms, etc., the MDT planning, and also their outreach work for their priority neighbourhoods. And we will, you can see some of the figures. These were actually April-May figures. Actually, now we've got, if you're looking at CGAs, which are comprehensive geriatric assessments, which are the gold standard for assessing frail, complex people in the community. They can take about 2 hours to do, but we're now up to about 450, and we've got 600 people who have been through frailty MDTs over Herefordshire as well. On the right is just a case example showing, in fact, a lot of this planning doesn't fit neatly into care pathways, which you may find sort of are very medical. Actually, sometimes it's about bridges of trust with people who are feeling relatively isolated from the system. And in this case on the right, where we have a complex patient who's got lots of issues, the outcome of the MDT really was to enhance the role of district nurses who had a bridge of trust with this particular individual, and were able then to orchestrate and organise his care that he needed, so that his care was not as chaotic as it had been before. So sometimes it's about having to be flexible with how we deliver services, so that they are focused around the individual rather than the organisation that wants to deliver it. Next slide. Okay, so Neighbourhood Health Delivery Board, we have 11 work streams, and these are them. They've been broken down each with a lead SRO, and then we have the enabling work streams of estates, digital and data, finance, and contracting. So these are all have associated targets with them, and each of them have metrics. So these are reporting back. So we are constructing now our dashboards to produce the outcomes for all these areas. Next slide, please. So this is just an example of one. So we are now moving into the phase of neighbourhood health being a programme with a workbook with clear measurables. So this is workstream 1, which is the urgent neighbourhood services. And you can see that first circle around the centre there. They are the things that will be reported back to the Neighbourhood Health Delivery Board, and if they are red or not performing, the outer circle are those sort of metrics which are owned by the SRO for that particular work stream. So they will have a sight about why that particular area isn't working because of problems, and that will be reported back to the Neighbourhood Health Delivery Board, where we would hopefully try and unblock, through partnership working, some of the issues that are causing us not to be on target. Next slide, please. So how are we doing? Is it worth it? You will be aware of the border issues here. What we are seeing is in 25-26, as you can see here, the emergency admissions were actually reduced from Herefordshire patients. Unfortunately, it was completely masked by an increase in the admissions from Powys. Our hospital provides a district general hospital function for Powys. They don't have some of that at-scale coordination and prevention that we have yet. They are working on it, but I can think the issue for us here in Herefordshire is we have decreased the number of emergency admissions, but we cannot release the funds from the hospital because they are effectively being consumed by an increase in activity from Wales. And now there is a wider political aspect to that, but that's, I think, really useful for people to understand that we are having an impact, but the complexity of where we are is causing us issues. Next slide, please. And this is just our dashboard, which is under construction, showing those metrics that I was talking about earlier. Just so workstream dashboards, neighbourhood board dashboard with the broader targets that we're trying to hit, and then how that reflects into the national metrics. Next slide. Okay, so this is the last slide. So what are the opportunities? Where are we going next? So the ICB has given 1.5 million to neighbourhood health in Herefordshire, and at Partnership Board we are working through with our host provider how we can most usefully spend that. The business case is being put together for the single point of access hub to become 24/7, which will consume some of that resource, and then expanding our prevention and proactive care through neighbourhoods would be another additional use. So that is quite an opportunity that we can perhaps move faster with that extra resource. What we're looking to do is expand that Nelson House capacity to drive increased coordination of our cohorts of highest need. And I think integrating with the Community Diagnostic Centre, which has been a considerable investment in community diagnostics, and making sure that is being used in our new community pathways so people can get their tests done without needing to go to hospital, is also an exciting opportunity. So I think, Councillor, that's probably all I wanted to say, but I'm happy to answer any questions.
Thank you. I've got a couple of questions before I open it up to the rest of the board. So one of my questions, I look at your hub and spoke diagram, and I obviously recognise that the hub is either an existing building, which it might be, which it could be a community hospital, or it might be a new build or another building that's in that area. So if it's a community hospital, I think we would be pleased, because we've asked for a long time now for community hospitals to be reopened and be used as community hospitals and they're not being done so in the way we want them. But my concern regarding both, well, all of this really, my knowledge is mainly of the north and the west, and I can see roughly where my group of practices are. Now, from what I've read, the hub will be open till 8 o'clock in the evening. Well, there certainly is no bus services that run. Well, in most of my ward, there's no buses that run at all. We don't have any whatsoever. So unless you've got a car, you wouldn't even be able to get to the hub. But the bus services don't run up to 8 o'clock in the evening anyway. So you've got a group of people there that could use the hub, but they can't because there is no means of getting to it. And I don't know what discussions, if any, you've had with the public service bus companies about increasing the length of their service to 8 o'clock or beyond, because at the moment that just isn't going to work. And the other one I just queried was that you Powys borders my ward, so I know exactly the problems with Powys because my residents there use Powys as their GP, and they use Hereford Hospital when they need to go into hospital or have an outpatient appointment, or they might be able to use some of these other facilities, but you haven't said they can. So I don't know whether the hub and spoke, or rather the spoke, because they're in Herefordshire, but they haven't got their GP is in Prestine, say, they presumably will not be part of this hub and spoke, and yet they use Hereford Hospital. And I'd be really interested to know. It's all very well showing some figures that show a significant increase with regards to trying to get discharged people from Powys, but what are we doing what are we doing about it? What are we trying to do to reduce that? Because this has been an issue that we've been talking about for years now. We know that the hospital needs Powys in order to operate because they need the income that comes from Powys. But at the present moment in time, sometimes it's at the detriment of people in Herefordshire, which doesn't seem fair to me. And I want to know who you are talking to, what level you are at talking to. Is it government level? Is it the Welsh Assembly? Where are you talking in order to try to change their way of discharge? Thank you.
Thank you. I'll have a go. I will probably defer that last question to Sarah Shingler, who's been probably more involved in some of those broader conversations. But in essence, from the neighbourhood health point of view, we have made connections with our colleagues in Powys. They are looking to expand their community response and have some resource to be able to do that. And we're working with them to see how we can better coordinate that, and so there can be learning on both sides. So that work has started, but it's early days. So just before I hand over to Sarah on that, just going through your other points, I think the community hospital issue, I think that's exactly right. I think we do need to sort of repurpose our community hospitals as able into being better community resources, and really to support our population to be out of hospital rather than in hospital. So I would be very keen to see them over a period of time being used more in that proactive space, perhaps as a hub for these comprehensive geriatric assessments, etc., so that we can keep people more reliant or give them more resilience, give them the services they need to wrap around them and keep them out of hospital. Yes, the hub and spoke issue is we very much have to think about the hours of opening, etc. There is an issue that we are all familiar with transport in Herefordshire, and that is the huge issue with rurality that we face, and that's why when things can be done centrally or remotely, so care coordination, that will probably be happen in the middle. Our hub there will be open 24/7 because we've got the GP out of hours co-located, and where possible we will then extend services. I think the estate's strategy is relatively new, so this has been sort of triggered as a response to some national innovation around funding. And I guess there is quite a lot of that to work through, but absolutely right. We know that there are a huge number of people, particularly children, young people, who are reliant on other family members for transport, etc. And that has huge implications for delivery of healthcare for all sorts of groups. So I think really, really important. Don't have the answers to that. I think that's probably where, joined up working, we have to have those conversations once we've got a sort of firmed up model for how that's going to work. And of course, public transport coming into the centre for routine checks. A lot of those market towns do feed into the centre, which makes it sensible to have a hub and spoke model. But also, we've got to make sure that they've got the appropriate services so that they can access the appropriate care. Sarah, I don't know if you wanted to come in and you've been having sort of higher level conversations about power. So.
Can I just comment on the bits that you've said first?
Sorry.
First, Phil. So, in the rural areas, there is either no bus service or no bus service after 5 o'clock, even into the market town. So that's the situation. So they wouldn't even get to as far as the market town. But something you said regarding the community hospitals, you said could be used for elderly people with various things like ulcerated legs and whatever. That's not a hub. That's not what this is. So you're not looking. Do I get from this that you are not looking at, for example, Leominster Community Hospital being a hub for everybody? You're looking at another building that would which would be the hub. So is that land you've got or land we've got? I don't know.
Yeah.
Shall I come in, Nigel? Maybe. So we are we're just completing now a strategic review of the community hospitals, and what we are envisioning that they do become the kind of the hub of those local towns. So you'll still have inpatient services and ambulatory clinics in there. But where we want to move to is more into that voluntary sector space, to kind of meet the needs of those local communities. So each one will be different. And from the review that we've done across the 3 hospitals, there is space to do that. And as Nigel's referred to, there is some capital that we can actually use to make those buildings fit that purpose. So it will depend on the locality and what the needs of those populations are. Does that answer that, Councillor Gandhi?
Yes, it does.
Yep. Okay, so Powys. So I've had real high level conversations since coming into post. So met with the Welsh Assembly a couple of months ago, and we've also had now 2 meetings with our chair and the CEO of Powys Health Board, and we've actually agreed to set up a strategic meeting with my directors at Wide Valley and Powers Health Board directors, and the key focus is to get plans put in place for winter in relation to discharge, to assess pathways, because as we know, unfortunately, our Welsh patients are assessed in our beds, which is what causes the significant delay. And also admission avoidance, which both Nigel and Lauren are kind of supporting around the art of the possible with that. What is kind of, I would say, optimistic is that Powys, within their own business plan this year, have actually stated that they want to reduce their non-elective activity. So they want to do things in Powys to stop patients actually having to come over to the border to care for them at home, which is great because that's the right thing for patients. And maybe look at stepping up that elective activity, which again is great from a waiting list perspective. So I would say, and what I'm told is that we're in a much more positive position than we've been for quite a few years. You know, there's been some changes in the leadership team in Powys Health Board. The conversation with the money is still ongoing, you know, and that very much is national to national conversations. So, you know, we are making inroads, I would say, but not out the woods yet.
Thank you. Jonathan, why don't you put your hand up first?
Thank you very much, Chair, and thank you to Nigel and to Sarah. Just an observation, I know it's very difficult to come up with a vision. I've been charged with doing one myself, but I would just take issue with the fact that no one dies well. So I think that the point I would like to make is that what I think is trying to be expressed is a lifetime of living well. And you get to the end of your life in a way that that you know you live well to the end of your life rather than you're dying well. Someone who looked after two terminally ill parents and watched them to the very end. There's nothing well about that. I mean, I came up with a vision for Herefordshire Council, which is to deliver the best for Herefordshire in everything we do. And if you translate that to that vision, it's the best death. And, you know, I just don't think that works. But what I think is trying to be encapsulated is good health care and a good, healthy life right to the very end. And I think if you express it that way, you get away from the point about dying and you know, there's nothing good about dying, so that's not a well thing. I'm just looking at this from the political lens because I know that from the other 52 councillors, three of which are in the room, we're looking at this in a very positive light because we want there to be better care locally, and that's a real positive step in the direction, and I see this initiative as being something that's really going to alleviate people's fears about primary health care, and this is a step in the right direction. I'm just trying to get my head around the map and the One Herefordshire Neighbourhood estate strategy, and I find that to be a very confusing presentation because I think that's supposed to be the map of Herefordshire, but it seems to have been squashed, so we're not clear on where it is. But you've got the East Neighbourhood in the southwest quadrant of the diagram, so it should be the opposite side. And then you've got the north and the west in the east, so that should be shunted over. I'm not quite sure what you do with the north bit, but the west bit, but I take that point. And then you've got Belmont, where Ledbury is. So I think that map it is really misleading. And I think if this was a document that's going to present where you are and where you can access your local services, if this is a front-facing document, it might just be a strategic document, but if it's a front-facing document, then that's disorientating. But then, thank you, Nigel, for your presentation. But when I look at services in my area, which the chair did as well, and one naturally looks at it through that lens, just trying to get yourself orientated as to where you are. it comes up with Nunwell, and I can see that being a real positive for Bromyard, but let's just press pause on that, because my next question is, well, what in terms of this model is happening with the hospitals? Now, Sarah, you mentioned hospitals being a place for neighbourhood, and there's part of a strategy that's being developed, but I see that as an integral part of this project. And so I'm thinking, well, I'm staring at half the document here. I'm staring at half the strategy here, because I need to know what's happening to Ross Hospital, Leominster Hospital, Bromyard Hospital in relation to this. Then the last point I would make is, if I've interpreted this correctly, this is opening the doors to GP surgeries in a whole new way, I assume. But I'm looking for some real green lights here as to how this will transform the access to surgeries. But apart from I think it's the column on the right under the blue heading, is that where we're demonstrating that GP surgeries are going to be revolutionised because you will have greater access to them so that members of the public can get their primary care? Is that what it's trying to encapsulate?
So perhaps I should
I thought it was the hub.
respond?
Yes, please.
Thank you. Yes, so I think with the GP access, if I can take that one first, that's one of our work streams. What we're looking at here is a much more coordinated, integrated sort of response. So it's not only the things that you would traditionally find in your GP surgery, but actually you'll be looking at services that may be voluntary sector, that might be sit within community services, which traditionally have been not well integrated together. So it is not just about the sort of GP access component, although that is one of our work streams. When we're talking about putting it all together, it is more about that integrated response. So sometimes it might well be someone from community services responding to the particular issue rather than a GP thing. The GP metrics for monitoring GP access, the ICB has had to put a plan to NHS England for GP access and the improvements that need to take place, and are reporting on that, and there are some ambitious national targets on that. Herefordshire is generally performing well on those. So I know there's a lot of noise in the system, but actually nationally we are very much at the top of the league tables as far as the numbers of appointments and the speed of being seen. So, but we will continue to keep an eye on that, because it's not always it's not perhaps everywhere, and that variation is where we probably need to sort of drill down to in our improvement plan. Just on the other issues, I take your point about the estates map. That probably does need clarification and tidying, so I'll take that away. Thank you for that, Jonathan. And your first point about the not being a good death, I think we have the palliative care services very much embedded into our neighbourhood delivery, and whereas there's certainly a bad death. So if you are in the last week of your life and you're spending it on a trolley in a hospital, that is really surrounded by strangers in a noisy, chaotic environment. That is a bad death. What a good death, in the context of, yes, nobody wants to go through it, but actually it happens to all of us. It's about having respect. It's about having your loved ones around you and feeling supported and safe and some dignity. And I think that's what was trying to be captured from the palliative care point of view, and the difference between those two outcomes.
Yes,
Thank you, Carol. Yeah. Okay. No, I get the part about palliative care, but you want as meaningful experience as possible rather than dying well. Is my point.
Sure.
But so as I understand from this, therefore, that okay, I take the point about GPs and you can access your GP, and statistically we're better than others, so there's not a problem to worry there. But for me, this was a political solution to getting better healthcare locally, and so I thought that if Nunwell, let's say for argument's sake, is going to be a hub, it's not a question of, well, I need to see my GP. It's I need to have my bandage changed. I need to have my chronic illness managed. And I thought that this model was going to be opening up services where people could access that, so that they don't have to go to A&E. They don't have to go to have another GP appointment and wait on the GP waiting list and whatnot. It was having better access to medical provision without having to wait and wait and wait. Now, I understand the idea that, if you have a hub that can integrate the charity sector and the voluntary sector to care for some needs, that's all well and good. And if Nunwell or others surgeries here like Pendine play a signposting role to all of this, then I get that. But there's still, in my view, the thought that what I thought the neighbourhood health plan was to get greater access to medical need. Greater access to professionals who could cope with medical needs, rather than signposting to a charity.
Well, I think it's probably both there. I think you're right. It is about doing more. We don't have a huge amount of different resource, however, but it is about. But it's also about targeting what we do to those of the highest need. So if we think about, we're going to be looking at probably the 3% highest need patients in our communities. Actually, we need to proactively manage those, provide better access, and you're exactly right. We need to do it closer to home in our rural areas. It's because it's not going to be easy to do that in any other way. So I think the neighbourhood plan is exactly about that. It's about targeting. The estate strategy is around enabling the delivery of those new neighbourhood services, those integrated care. So we are proactively identifying those at higher risk. We are care planning with them what their needs are. We are optimising their long-term conditions and hopefully preventing unnecessary use of urgent services, including hospital admission.
Sarah, did you want to come in?
Yeah, and Nigel's covered it. It was really just the point around the strategic review that we're doing around the community hospitals, and that is being done with our partners. So it's being done in that neighbourhood space. So we aren't doing something separate as to what we're trying to achieve within the programme that Nigel's outlined. And as I said, we will look at those local communities, at what is required in each of those community hospital footprints. So that's kind of the work that we're doing and scoping now, so that they do become those community hubs of the future. But it's not something that we can do overnight. No. As Nigel said, we do have a little bit of capital, but we haven't got loads of money for revenue, so for staffing and resource. So that's kind of what we're working through, what we can achieve over a 2-year period.
Joanna.
Thank you, Chair. And for colleagues I haven't met, I'm Jo Newton, Independent Chair of the Adult Safeguarding Board. Nigel, thank you very much for the presentation. It's really good to see progress, and especially anything to do with integration and partnership working. Prevention is one of our 3 strategic objectives with our safeguarding strategy. And I just wondered if there's any advice or thought or thinking you'd had about how you might want to integrate adult safeguarding into the work you're doing, or that may be something to come back to. And I have a second question, which is, as a member of the public, how do I know how to access this exciting new neighbourhood team working and not pitch up to the A&E department? Thank you.
Thank you, Jo. Yes, so I think the adult safeguarding bit, absolutely critical. And I think what's happening, of course, is our PCNs are developing into our neighbourhoods, and our safeguarding leads are all at PCN stroke neighbourhood level now. So they are, so certainly in the city, we are having child and adult safeguarding discussions as part of MDT discussions, looking at the most vulnerable in our communities. So we would be having those. So I think it's the safeguarding is completely embedded into these new ways of working, and I think we've just got to make sure that it continues to do so. I think we do have a more developed safeguarding model than some more traditional parts of the country because of our investment into PCN level delivery. Certainly within my primary care network, we have a safeguarding team who are extremely proactive and risk scoring, etc., and are feeding back to all the clinicians the whole time. So I'm pleased that we are there. Is there more to do? Of course, and I think we've just got to make sure that safeguarding, we continually check that safeguarding remains at the heart of the new neighbourhood services, and I think the proactive care, I think we shouldn't be asking some of our most complex patients to do some of the most complex navigation of our system. What we should be doing is identifying them and then wrapping the care. Okay, we should be approaching them in the way that's most suitable for them, but actually we're in this terrible dilemma in the health service at the moment where the more complex your care needs are, the more complex it is to navigate, and any of us who have looked after elderly relatives will be able to say that it does get extremely complicated. We need to change that. So what we need to do is get around so that your team wraps around you. And I guess some of that care coordination focus, which I would like to see expanded in our neighbourhood hub, I think that's the key to that. I think actually we shouldn't be asking people to try and sort of navigate complex systems which are almost impenetrable in that, even for those who understand them. So I think this is about wrapping care and bundles of care and integrated working, but not expecting the individual to have to try and do that themselves.
Sarah?
Yeah, just adding on to Nigel, what we are looking at within the single point of access 24/7 model is actually families or patients being able to contact directly through the hub, whereas at the moment it is only for professionals to be doing that. So that means that hopefully, if it's not life-threatening, that those patients or family members would actually contact the 24/7 hub as opposed to 111 or dialing 999. And that way then we can provide support or get a relevant team member out to see them. And that takes away the complexity of trying to navigate a really complex system. And we're looking for that to start September, October time.
Thank you. Steve, do you want to?
Just I'm grateful for the mention of the voluntary sector, but sorry to sound like a broken record on this, but the resources for the voluntary sector to respond positively, resources need to flow and follow. They're ready, willing, and able to stand and ready, but they can't just do it on best wishes. The resources do need to follow. And I did have it might lead into I'm curious about the thinking and objectives around Neighbourhood Health Investment Fund in terms of, is that an opportunity for the VCSC sector to respond positively?
Yeah, so absolutely. I think one of the things that has sort of been extremely challenging is that there has been no additional funds so far for neighbourhood health delivery. It's existing redirection of resources. So that makes it even more difficult if we're trying to move money between sectors. So because that means someone has to stop doing something, decommission themselves to release the money. So I think we've all been struggling with that frustration. It would have been very nice to have had a pot of resource to get neighbourhood health going. I think that's what the ICB are trying to do with this, and I think it does create an opportunity for the voluntary sector and community, but we have to do that in an integrated way. So, yes, I think that is a distinct opportunity. I think we have to. That fund is for making an impact in year, if you like, on some of those key metrics, such as reducing emergency admissions to hospital. So, yes, but actually the voluntary sector have got a huge amount to offer in supporting some of our most vulnerable cohorts. So I could see that very much being part of that.
Sarah?
Yeah, so in answer to the question, yes, that there is the 1.5 million left shift funding around neighbourhood health, and we are just doing a pilot now in the single point of access around having the voluntary sector actually based alongside the call handlers and the clinicians to actually sort of begin to scope how the voluntary sector can support us in that admission avoidance, attendance avoidance. And there is, you know, we know, and we're just looking at what we're spending that 1.5 million on, and the voluntary sector is certainly in the room and around the table on developing and scoping what that could look like. So there's a single point of access that we're funding 24/7. There will be funding that is going into the integrated neighbourhood teams, which Nigel's talked a lot about those in his presentation and in his answers. And then we do want to look at something around the Better Care Fund, and I don't know whether Hillary's in the room, but we are looking to kind of change the way we're commissioning part of the D2A pathway. So again, with the voluntary sector being more involved with that. So Hillary might want to say a bit more. So we are absolutely working hand in hand. And once we know what the model looks like for the 24/7 single point of access, then that will be part of that will be provided by the voluntary sector with associated funding.
Thank you. And I'm being a bit parochial now. I noticed that on the GP side that you're talking about flexible rooms for staff visiting. So I live in Alton. My surgery was a 2-bedroom bungalow that's been made into a surgery. We have one GP at any time and one nurse, and there aren't any other rooms available. So I don't know quite, and if the residents of the area that use this particular surgery saw anything like this, they would immediately think they're going to lose that surgery, because there's no way you can build onto it to make it, to extend it, and it is what it is. And I don't know how many other surgeries in the rural areas where they've been put up because there was a need, and I know with in Alton it was because it had virtually no houses at all, and then suddenly in 1970 something a lot of houses were built, mainly bungalows with older people in, and so they decided one of those bungalows has got to be a GP's practice, and that's what it is with one GP. It's a single working GP, and I suspect across the county there are a number of cases where that has occurred. So the flexibility for visiting staff maybe a bit difficult unless they're in the waiting room.
Yeah, no, absolutely get your point. And again, this is the challenge, isn't it? Some of the national language about neighbourhood health centres doesn't translate very well into the reality of rural dispersed healthcare, which I think is what you're describing. So I think we have to look, and we're already seeing some change in the language. Some people are talking about campus services. So actually, it may just be a number of buildings that are coming together to produce a service which is working together. And I think that's some of the work that we need to do with the community resources to make sure that, yes, it's not going to be one size fits all, particularly for our rural communities. It's going to be, how do we get the services that that community needs, and how can we be inventive about making it work using a mixture of health and community assets. And I would see us having to work through that.
You work in the pub. Zoe.
And actually following on from that, I think we've covered a huge amount of ground in terms of Nigel's very helpful update. But I guess it's just to point out that actually the opportunity still exists for us here to shape this in a way that is right for people in Herefordshire. And that really means actually delivering at that really local, hyper-local level in terms of neighbourhood health. So we've talked quite a lot about estates, and we've talked about medical care around that as well, and the shift away from hospital to community and the opportunity that exists around that. We've talked very little about prevention. We've talked quite a bit about the 2 or 3%, but actually we need to shift that as well to stop people becoming the 2 or 3% as well. And we mustn't lose sight of that. And certainly that's where I see that the voluntary and community sector have a really strong role in that, heard very loud and clear in terms of how we resource that and how we do things differently. So I would just sort of reflect back that it feels like we're still at the very beginning of this journey, but it is ours to shape, and the people in this room can help do that.
Thank you, Zoe. That was a very positive point on what, when some of us are reading this, is interesting. I mean, anybody reading this who lives in a market town or in the city would probably find this absolutely okay. The trouble is 2/3 of our population live in the rural areas, and it won't work in the rural areas. And so you're absolutely right. We have the right, and we will shape it so that it fits for what Herefordshire needs, and not an urban area.
And totally, and I think we can get very hung up on the estates part of it, and that's just part of the picture. So you know me, I'm always very positive about the future, and I think that this creates an opportunity for us. The estates bit is some of it, but actually the data and the intelligence and understanding our communities at those neighbourhood levels, and then actually what we put around that, which some of that is health services, but some of it is much broader than that, to prevent people becoming that 2 or 3%.
Absolutely. Anybody else? Oh, Simon.
Yeah, I wanted to be positive as well, if I could, Chair, because we had the national lead for this, Dr. Claire Fuller, visited the ICB cluster area 2 weeks ago today, actually, and Nigel and Sarah presented to her, along with representatives from the other 3 areas the ICB covers. To be honest, the feedback we've had from that visit has been really, really positive, to the extent that we're being told that whilst it's not perfect, the story we've developed, and as we've talked about here today, Herefordshire, Worcestershire, Coventry and Warwickshire are ahead of all of the other areas in the country in our thinking. I think it's a classic case of high-level government policy, not a lot of detail behind it, zero additional funding following that policy, and locally us trying to make the best of that situation and come up with a plan and a story that works for us, works for Herefordshire. And I think what Nigel and Sarah have done is they've made a really good start to putting that together. And if it gives you and other board members confidence, genuinely, relative to other areas, I think we are well ahead in our thinking. So, of course, that's a great start. What matters is how we translate that into better outcomes for patients. But this is an area that Herefordshire is, you know, amongst the front runners in the country on the thinking that the team have developed.
And just a last question, if anyone has got any other questions. Within the next couple of weeks, we should know the outcome of Worcestershire and Gloucestershire, and Warwickshire as well. And that may change your footprint. And would that then, would that impact upon the Herefordshire part of the footprint?
I mean, it's a really good question and very timely, as you say, because this week, before parliamentary recess, which I think is Thursday, the Ministry of Housing and Local Communities and Government are supposed to be announcing the outcome of the applications people have made to form unitary councils. Worcestershire, Warwickshire and Gloucestershire are all in that category. I think we'll wait and see whether that announcement happens, because it's in the middle of a change in Prime Minister as well, isn't it, which may have an impact. From an ICB point of view, we've stuck to our guns. We're going to be sticking with the footprint we've got now for the next 2 or 3 years, because we need to know the decision of which unitary authorities are going to be formed. Those unitary authorities then need to actually come into existence. They need to elect some councillors, they need to appoint a chief executive and all of that stuff. And then those new unitary councils need to decide which strategic mayoral authorities they want to be members of. And that's, of course, a decision that Jonathan and his team will also have to take. Which strategic mayoral authority do we want to join? When all of that's happened, and it can't happen really before the 2028-29 financial year, we will then sit down and look again at the ICB boundaries and how we get alignment. But for now, for this year, for next year and the year after, we're going to crack on with this work and try and make as much progress as we can. I mean, the only other thing I'd say is the way we are working is very place driven. So it's a strategic ICB with place-based leadership, and you've heard from the place-based leadership this afternoon. And really, I don't suppose it matters that much for Nigel and Sarah and the team which ICB they're in, because the place-based structures are driving the car and are running the show. And that is very much the intention as to how we would like to work.
Thank you, Simon. So has anybody else got Jonathan?
Yes, thank you. I mean, one other thing that strikes me is Nigel and Sarah has done a valiant effort of trying to explain to the board a scenario with many moving parts. So it's very difficult to articulate that. I was just thinking maybe what I think might help when this gets fed back to various organisations, the council being one of them, is there an opportunity to set out a case study of examples of where we have this scenario and we think that adopting this model will improve the way that that scenario plays out in the system. And the benefit of that would also be that in explanation of that case study, you could integrate it with the outcomes that one would expect with the voluntary sector, with the care sector, with the charity sector. So it's really highlighting, look, this is a new model. This is what was happening before. This is a way that we think this model will improve the outcomes for these individuals. And then if you've got a couple of case studies like that, you then begin to understand the system better and how it's trying to gear itself to improve those outcomes in that sense. And then you can also have a case study like that where we include Zoe's point about prevention. So I think that would help, I think, in explaining this, because I'm always looking at these things as to great to all get together to try and improve things, but how do we articulate that so it's embedded in our own psyche as well as members of the public who are going to be receiving the benefits of this if it all goes accordingly, because it's a much more integrated approach. That then leads me on to, if we've got a good case study or case studies and we explain the integrated nature of what we're trying to achieve here, it then also, I'm just curious about how is this being articulated. I've scribbled down comms because that's my just B word for, how we're going to explain this to members of the public. But is there a strategy for the comms and when is the start date? Hilary said to me there are bits of where this is already happening, but do we have a hard start date as to, right, this is the picture now, so we're going to, from this date forward, we're going to move into this space with this model? So that's a question. And then if we are explaining when it is that this model is now live and operational and this is the way we do things from now on, that has still got to have fed into it, hasn't it? The decision about how best the hospitals will be used to help further this initiative. So if we start with a hard date, is the use of hospitals going to come along 6 months down the line or something like that? Those are the things that I'm just still trying to reconcile in my own mind. Thank you.
Sarah?
Okay, so if I go in reverse order there, so the hospitals, what we're having to do is to prioritise, because as Nigel's touched on, there's been no additional capacity from a workforce perspective, either in kind of management support or project management support. So we are prioritising the key projects to mobilise for winter, and that's the single point of access going 24/7 and more resource into the integrated neighbourhood teams, which will be reviewing those the top 3% of the local populations. But we plan to have the strategic review of the community hospitals completed by sort of September, October time. Then with a view to actually starting to implement changes within those hospitals from March, April next financial year. And it is because we're working at such a fast pace that we just physically cannot do everything, because we do not have the leadership manpower or the additional staffing that's required. So we are already operational with the pilot integrated neighbourhood team in the city, which Nigel touched on, and the single point of access will go live by end of September 24/7, as will hopefully the 24/7 end of life palliative care line, which the commissioners are just in the process of commissioning. So there are a number of changes that should really impact on admission and attendance avoidance for the winter.
Thank you, Sarah. Oh, Nigel, sorry.
Yeah, yes, Jonathan. I think I think it would be useful to have case studies. It does. You're quite right. There is lots of moving parts to this. This is complex program of changes which are coming in, and actually how that translates down to the personal level is going to be really important. So we have a number already of those sort of case studies, but I think we should be capturing more, and we can feedback some more here if that would be useful as we progress, because I think that I think it makes it real then for everybody. The comms side of things has been a challenge for us in that we have lots of comms teams who are very focused in their own organisations, and we have brought them together with a rotating lead, but with no extra capacity. So so I think they are quite stretched, but I think that's something which we do need to get right, because we need to be able to tell the story, and we need to be able to get the message across about why there are some changes. But I think that's kind of links into, we have had a limited executive capacity for all this. So we are doing what we can with what we've got, but there isn't, we don't have that additional resource, which makes it having a program team sort of created with comms. We have to work together, so we're going to rely on all the partner organisations. General practice doesn't really have a comms capability. Obviously, trusts do, and the local authority do. So we probably have to work harder on aligning and getting the messages out on this. I think that's a good criticism.
And this is any more questions. I think we spent quite a long time on this. We'll move to the. Well, thank you for the presentation. And we move to the recommendations, which are that the covering report recommends that the Wealth and Wellbeing Board note local progress in developing neighbourhood health. I need a proposer. David, a seconder, Simon. Thank you. So we now move on to item 8, which is the best start in life, good level of development in children aged 5, and will be presented by Zoe Clifford, and the presentation and then will be done by the clerk, and Liz Farr and Julia Stevens will presumably input into the presentation. Thank you.
Thank you. So not presented by me, I'll just introduce it and I'll leave it to the team to give much more detailed presentation. If we can share the slides, please. Okay, so as you're all aware, Best Start in Life is one of our 2 priorities as a board. A clear overlaps between this and the other priority anyway in terms of better mental well-being. So as well as being one of our 2 key priorities, and we're bringing today an update around it with a very specific focus on the good level of development. Now, the reason for that is last year there was a national document around giving every child the best start in life, and that clearly set out a national target around good level of development. So by the end of reception year, of getting 75% of children nationally to what is deemed a good level of development. And we'll go into more detail about what that actually means. But bearing in mind then we've got a national target and then there's a local target that's attached to that as well. I also wanted to draw your attention to, we've got a regional public health critical 6 for 26, and that focuses on infant mortality, increasing the good level of development at reception age, prevalence of smoking, CVD, young people's mental health needs and TB. So clearly overlaps there in terms of best start in life and those 6 priorities that are for the Midlands as well. So I just wanted to set that in that context, and then I'll hand you over for a clearer explanation in terms of our progress and target around good level of development in Herefordshire.
Thank you, Liz.
Thank you. Hello, everybody. It's nice to be here this afternoon. Next slide, please. So if I take you through the early years foundation stage with just a little bit of background information, I thought that would be helpful. So we are referring to a statutory assessment that's completed at the end of reception year with all our little people who are usually aged 5 at this point. It gives us a national picture of children's development. Don't panic, they don't sit some great exam in some exam hall aged 5. This is ongoing teacher assessment of children's development against 17 early learning goals, which are set out across the 7 areas of learning. And our practitioners at the end of reception use this information to help support children transitioning into Key Stage 1. So that's our 5, 6, 7-year-olds in learning, where perhaps you're familiar with learning becomes a little bit more formalised at that stage in the curriculum. It also helps to inform parents around their children's development, as well as provide the data for us to benchmark. Our practitioners complete an observation of children in the first 6 weeks of reception, which helps track their progress then over the course of that first year in school. And then after that, we have ongoing observations and assessments throughout the year, and that helps to inform that good level of development measure. Thank you. Next slide, please. So when I'm referring to a good level of development, what is that? So it this measure doesn't include all areas of learning in reception, just this hand-selected bunch you can see on the slide. So in order for children to achieve a good level of development, they have to meet the expected standard in those areas of learning. There's a couple of other areas of learning that fall outside of that. And that helps us to make that measure at the end of reception and to evaluate the effectiveness of early years, both locally, of course, and at a national level. Thank you. Next slide. Now, this is a really optimistic piece in Herefordshire, so I'm trying to turn the positivity tap up here a little as I go through these slides. So the government has some ambition for children in the early years. The government has stated that by 2028 they want 75% of children in reception to achieve that good level of development that I've outlined in those key areas of learning. And nationally, currently, about 68% of children achieve a good level of development. So you can see there the increasing ambition for children to get off to a great start in their early schooling and be well prepared for school life as it lies ahead, where there will be exams and tests around the corner, not just observations. There is, of course, a gap here as well in terms of vulnerability, and our children who qualify for free school meals, only 51% of that cohort achieve a good level of development by the end of reception. These are national figures. Compared to the comparator group, the non-free school meal children group, nationally 72% of that cohort achieve a good level of development. So you can see the gap there emerging already. The gap is even wider when you consider children with additional needs, and only approximately 20% of children with special educational needs nationally achieve a good level of development by the end of reception. So you can already see those stark differences emerging nationally between those cohorts. Thank you. Next slide, please. So Herefordshire, how do we sit against that national picture? And for us in education, we're really proud of this data set and have been over some time. So at the last point of reporting, we had 72% of our reception cohort achieve a good level of development. So you can see that is above the national picture. Every local authority, I understand, has been set good level of development targets across England, and they vary quite considerably, is my understanding. So Herefordshire has been set, as you can see, an incredibly ambitious target, which is going to keep us on our toes, and we are aiming for 80% of our reception cohort to achieve that expected standard, that good level of development by 2028. And we are rising to that challenge already. Again, our free school meal children, our sort of disadvantaged cohort, if you will, we're in line there with the national picture. But again, we've been set a statutory target of just over 57% of that cohort to achieve a good level of development. In our reception cohorts, for your background information, we have approximately 1,600 children across 70 settings or so. Thank you. Next slide, please. And I'm going to hand over to my learned colleague for this part.
Afternoon, Julia Stevens, Public Health Lead for Children and Families, and I also lead on the Best Start in Life strategic plan. Just winding back the years slightly from the age of 5, we have children who are 2.5 and 3 years, of course we do, in our communities, and Public Health commission the Public Health Nursing Service. So that's our health visitors as school nurses. And the health visiting service deliver 5 mandated health checks, of which one of them is the 2.5-year child readiness review, and we have included an additional health check this last 18 months at 3 years. So children are assessed much earlier than 5 years old when they're assessed for a good level of development. But these 2 additional checks are fundamental in helping and supporting those children from a very young age. I think it's quite difficult to believe sometimes that you have a little child at 2.5 and already they are being assessed. I hate to use that word. I'd rather like to use the words that they are being supported and monitored in their young lives. You can see 3 pictures there of all those children happily getting on with their little lives, unaware of all of us strategic officers and professionals, you know, monitoring them behind the scenes to make sure that they do well. Now, with regards to the 2.5-year child readiness review, we call this the 2.5-year integrated review. Integrated because in an ideal world, we want this review to be with the parent, with the nursery provider, as well as the health visitor. So you've got a health education and the parent contributing to that review and seeing a perspective from all 3 professionals. I always call a parent a professional because they are professional in bringing up their children. And this review covers speech, language and communication. It monitors their physical growth and development, and it identifies, you know, very early their social, emotional and behavioural patterns and concerns that a parent might be worried about. And it also is an opportunity to promote healthy eating, physical activity and of course oral health. And it also is an opportunity at that review for parents and families to be signposted if they are picking up any early support services that might be needed for that family. So that's the 2.5-year child readiness review. If you move over to the next slide, please. The 3 years child readiness, and we call it child readiness because it's about a school being ready for a child, not necessarily the child being ready for school. That's debatable. People will have a different view on that, but in Herefordshire we call it a child readiness review. We prefer that terminology. And it's about very much integrating and making sure that that particular review that we in Herefordshire, I think, are probably one of the only local authorities that have built in an additional 3-year child readiness review within the 0 to 19 public health nursing service. And that review, again delivered by a health visiting service, is looking about the ongoing monitoring and development of that child. They would have seen it around 2.5 years, and they're now going to see it between 3 and 4 years before they start school. And it's a review of any early identification that might have arisen around sort of their social behaviour, concerns, and also it's about preparing them for nursery and school transitions, which is inevitable, and reinforcement of some key health messages. And just to note, this picture here, all these children are so excited that they're going to be starting their educational journey into nursery, not knowing at this stage that they've probably got 10, at least 10, if not more years ahead of them in the educational system. But if they do well, will have huge impacts on their adult life, which we'll talk a little bit about later. So just to go through, it's hard to believe, I think, that children at the age of 2.5 and 5, how they do in society within their early learning goals, how that is going to impact on their life. And I think this is a really key slide in just showing you that for children that do not do well at school and throughout their educational system, the impact on adult life is quite significant. So the investment and the health checks and the interventions that go in very early with these little ones is so important. I mean, it goes without saying, you know, our educated and clever and bright children are likely to go on and earn more money, have more successful jobs. I think we all understand that, it's a given. But not only that, children that do not reach a good level of development are more likely to have health literacy issues. They're more likely to suffer physical and mental health problems. And also, they're more likely to be less resilient and adaptable to life. So I think, you know, you take a 2.5-year-old and you look at them and you think, wow, how is that going to impact when you're older? And that is a really good slide around return on investment, etc., to how that is going to affect years later your adult life. Thank you. Next slide, please.
I must have had a vision before I came to board this afternoon that board does enjoy hearing a case study approach. So forgive me, we have included here a case study to illustrate some of the work that goes on. As I've mentioned previously, this is a data set that Herefordshire should be really proud of in terms of how well our children get off to a good start into Key Stage 1 and the proportion of children achieving a good level of development in Herefordshire has traditionally been higher than the national benchmark. But we're not resting on our laurels. We have been invited over time to take part in research, actually, to try and share with other areas what's been the secret to success here. Why are children getting off to a good start? Why is the proportion of children achieving a good level of development at the end of reception year above that seen nationally year on year on year? So our case study sort of illustrates some of the work that we've had and a focus on this. We had a small amount of underspend in 2018 and we had to make a decision about how we might use that. And so we formed a strategic group to look at county-wide programmes that had strong multi-agency working in order to really target this area. And we looked in a very focused way at upskilling our early years workforce, the practitioners who are working directly with our little people. And we looked at a training programme, we looked at consistency of practice and how we might support our early years settings more strongly. So in terms of what we implemented at this point, we looked very much at a county-wide speech and language service for our 2 to 5-year-olds in order to improve early identification, to improve workforce training. We developed a programme of communication leads and a toolkit to support our providers. We also looked at a parent and infant mental health approach using the Solihull approach to help, again, with workforce training and free online parenting courses. And the training that we implemented helped early years practitioners to improve school readiness, to improve children's behaviour at transition, and also provided some support around early literacy and mathematics. As a result of this, we were able to prioritise workforce skills and consistency, scalable evidence-based intervention programmes that have made a really sharp difference to improving outcomes, and of course on top of all of that, much stronger engagement with families and carers. So some of those things were identified as elements that have really supported children and families in that early years space and contributed strongly to improved outcomes. The real challenge, next slide please, is for us to continue to focus really strongly on our disadvantaged little children and make sure that the proportion of that cohort achieving a good level of development, and we need to remember at this point, this is just the kind of expected standard, that we increase the proportion of disadvantaged children achieving a good level of development at the end of reception. So already work is underway in terms of how we might all come together in this space to really target outcomes for those cohorts. You can see here on the slide we've outlined a number of initiatives that we have up and running. including we have a dedicated resource now looking at improvement for particularly around SEND in the early years setting. So we've got a practitioner working directly on supporting schools do their very best for that cohort. We have also delivered some neuro-inclusive education training. You can see there we've had high take-up across our schools and settings, who have been universally positive about the quality of that training and the difference it's making. We have a child readiness project that my colleague talked about earlier, where we get all of our lovely reception teachers across the county together to talk about the services that are available to them to support their ongoing work. And that's a joint sort of health initiative, education initiative, voluntary sector. It's the most wonderful day, actually, of getting to know what the resource is available to practitioners in Herefordshire. I must at this point as well talk about the early years improvement service here at Herefordshire Council. It is an exceptionally strong team led by our lead practitioner, Emily Garner. The engagement with schools and settings with that support service is quite immense. It's really impressive. So there are regular KIT meetings, for example, every term, where Emily and her team talk to the practitioners about their outcomes, about where further support might be needed, and we bring challenge as well. So we are keeping close watch on how those settings are performing. The penultimate bullet there refers to Ofsted inspections actually across Herefordshire, and again an exceptionally strong set of outcomes for both our reception cohorts and our nurseries and settings as well. So there's a lot of ongoing work and really strong engagement with the sector to continue to do all we can to raise outcomes for our disadvantaged cohort by the time they get to the end of their reception year. As my colleague said, we know if we don't close that gap really early, it widens through education, and it's very difficult for children to catch up those lost years. So it's really important we get this right in the 0 to 5 space, culminating in that reception year at the end of the early years foundation stage. So I was going to use the last couple of slides to just make a sort of call for action, if I may, Chair, in terms of, you know, what else we can all do in terms of this space. And it's certainly around sort of educating our parents around home learning environment, for example, the number of words that little people are exposed to, and those early experiences with vocabulary are really crucial. So activities around the old-fashioned things, I'm still very much an advocate for. The singing songs, the learning rhymes, the experiencing vocabulary at a very young age, all are really important factors in supporting children achieve those milestones. We also know that there is a link with quality childcare that is available. So some interesting stats there on that slide as well for you to digest. And group intervention programs, including supporting parents around expressive language and so on, can make a really marked difference in improving children's outcomes. So finally, more widely, we thought it was helpful just to mention some of the things we can do here at the council in terms of trying to raise that profile of children and families achieving a good level of development at the end of reception. There are things we can do here as employers with supporting our parents and carers around flexible working, enhanced parental leave, workplace parenting support. We know at Herefordshire we offer an extensive range of parenting programs, for example. All of those things contribute very strongly to trying to close some of this gap that I'm talking about. Do feel you can get involved as well with your local early years provider in your schools. I'm going to do a little bit of a shout out, Chair, if I may. We are always short across Herefordshire of professionals who contribute to school governing bodies, for example, and working in governance in schools. So there's another opportunity for members of the board to get involved in that way and support our practitioners in terms of raising standards. We are looking, as we've talked about in a multitude of ways, at a new way of working nationally around family hubs, community availability and so on, and families in the early years, they're getting the support they need. That's also a critical part of the new infrastructure. And I think probably most importantly, it's to advocate, all of us in this room, for the 0 to 5 early years agenda. I've talked a lot about what happens in reception year, which for many of you, of course, marks the first year of schooling, but is actually the final year of that early years developmental phase. So that 0 to 5 early years agenda, it's really critical to get that right and continue in the way that we've set the tone here in Herefordshire to be really a leading local authority in terms of getting children off to a great start in schooling, in order for them to thrive in the education years ahead, and then obviously into things like adult employment. We have to get it right at the earliest phase. Certainly I think there's a lot to be proud of here in Herefordshire about how we're doing that well and have traditionally done that well for a number of years. The challenge for us is to do even better for our disadvantaged cohorts and our SEND little people. Thank you, Chair.
Thank you. Do I have any questions? Jonathan? Oh, Zoe first.
Thank you. And I was just going to say, in terms of how you finished the inequalities side of it. So, you know, the team have pointed out that actually we perform really well as a county. But then when you look at, and we perform better than national as a county, and that's why we've got that stretch target. But then when you look at our children that are in receipt of free school meals, we're similar to national.
Yeah.
So that gulf is much wider. And then from the stats that you've just seen in terms of the knock-on effect that this has for well into adulthood, you know, Julie's presented the twice as likely to be unemployed by the age of 34. If you don't reach good level of development at end of reception, that's quite a stark figure. And I guess for me is that the solutions feel quite, in terms of evidence for solutions that are quite basic. You know, the second to last slide of 2 activities with your child, that there's evidence that if you were educated, stopped education at age 16, if you just do 2 activities at home with your child, sitting, reading to them, singing, whatever that is, then actually the difference and the impact that makes in terms of good level of development. So I do think we've got, sat around the table, representation from our key anchor organisations. We've got voluntary and community sector representation. We've all got a role in terms of how do we promote that good home learning environment for all of our parents so that we decrease that gap in terms of the inequalities.
Jonathan?
Yes, thank you. Great presentation. Thank you to both our colleagues. Just reminded me that Councillor Powell is on annual leave. That's why he's not here. And he asked me to send his apologies. So I should have mentioned that at the beginning. But he's just confirmed that. And given how hard Ivan works, I've allowed him to have some annual leave. So I think that's fair and justly deserved. Yeah, I mean, just following on from Zoe's point, really, just to ask my colleagues, you know, there's many things that individual organisations can do to promote the very things, and Zoe's given a brilliant example of just those 2 basic learnings can make a huge difference. Is there anything specifically that you think that the board as a board should be doing?
I think as a board, we've got that assurance role in terms of knowing that this is being looked at with children's, but actually as a board, we've got an interest in it in terms of that impact into adulthood. So I think we've got a target of it that we're due to deliver on in a couple of years' time. As a board, we should be holding people to account on the delivery of that target, keeping a clear eye on it. And for me, particularly around that inequalities. So yes, hitting the 80% target, but what about that inequalities gap? I would say that as a board, and then as individual organisations, what is our role within that? And there are some fairly simple things we can do in terms of raising the profile of this and articulating it in a way that's really simple and digestible for people.
Joanna.
Thank you. Just curious, really, your call to action. I love the whole presentation, and I think the essence of what you say is absolutely right. It's so refreshing not to have a presentation that mentions AI or mobile phones. But in terms of messaging, I'm assuming when we're talking about singing and reading stories, it's that personal interaction, isn't it? I just wanted to make sure. I think that's a message we need to make sure people get. It's not putting a mobile phone or an iPad in front of people with nursery rhymes. Or what's the evidence for that?
Yeah, no, there's actually a piece of work being done as part of the Best Start in Life around encouraging parents not to use tablets and phones as often as we do see them, and putting the phone down, because quite often you'll see people out pushing their prams and they're on their phones. There's a lot of work to do there around that, and I'd urge you all to support that in your own organisations as well, and challenge that, because that is huge. Children are, I think, suffering, and it will be detrimental to them because their parents are on their phones or their technology far more, and not necessarily doing the talking and the speaking that we would want them to be doing as often as we would want them to be doing it.
That's funny you should raise that, because I visited a fairly well-known centre, and they were saying, with regard to speech and language, that people make an assumption that children who suffer with poor speech and language come from areas of deprivation. But she said, in our particular unit, she said, we've got several children that suffer with issues around speech and language, and she said they don't come from deprivation. She said it's more a case of older mothers who have had a career and have then had their children later in life, and then expect to be able to continue the lifestyle that they had before. So the idea of coming home in the evening, having a meal, perhaps sitting down, watching the television, having a glass of wine or whatever, and in that time when you would normally be perhaps putting the child to bed or reading it a story or whatever, you're plonking the child in front of a television or an iPad or something like that. And she said it was a real eye-opener for us that actually there was a lot of people who came from very well-paid jobs who didn't want to give up the well, she referred to it as me time, the me time that they had before they had a family, and they wanted to continue that type of life, and that was the way they would do it. Anybody else with a question? Jonathan.
Thank you, Chair. I agree with Zoe's point about us monitoring the progress, but my question was more generically to the board. Is there anything we think we should be doing? Are you, as chair, writing a letter to various organisations, to government, to progress the issues that we face in Herefordshire? I mean, one of the things that I'm mindful of is we talk about children being disadvantaged so that when they come to try and find a job, they're going to be unemployed. But we have a very low wage economy, so there's a double whammy. So we've got real problems there as well. So, I'm just thinking, is there anything else? I don't have an answer, but I'm just thinking, is there anything else that we think collectively that the board should be pursuing, as well as doing the monitoring and making sure that we're on track? Is there anything else we could be doing as a board to raise the profile of this particular issue in Herefordshire?
Yes.
Thank you for that kind offer. I think so. I think our Herefordshire education settings are some of the lowest funded settings in the country. It is a different rate of funding for Herefordshire than many local authorities. So that sort of as well contribute, you know, it is testament to the high quality of work going on in our education providers that we can turn over statistics like this. So Schools Forum, which is a group of head teachers and education representatives, and Councillor Powell attends, continually advocate for fairer funding for Herefordshire schools through an organisation called the F40. And I think that it's imperative on all of us to continue to advocate for better funding for Herefordshire schools and settings than is currently the case. So I would urge board members to keep that at the forefront of your thinking as well. And I think there's, I always take these opportunities, as you know, to talk about SEND provision in Herefordshire. We've talked a little bit there about some of that early emerging gap as soon as the early years. There is more work for all of us to do to ensure that there is a school place in Herefordshire for all of our children, including our most complex children who require specialist education. We do have a shortfall, as many members here will be aware, of suitable school places for our most complex children. So we still need to continue to address that, including bringing representation where we can to the Department for Education about that provision in Herefordshire. Thank you.
Anybody else got any questions? No. Okay, so if I move to the recommendations, which is that the board considers the report and notes how a GLD affects the life course and the progress on the work being carried out to achieve a good level of development at the end of reception class for children aged 5 years in Herefordshire. Do I have a proposer? You want to say something? You wouldn't allow that in any of your meetings.
Well, it depends if the debate's been finished, but I mean, we've got a recommendation in front of us, but should there be recommendation B to say that the board recognises the report, the consequences of better funding for educational outcomes, and therefore we'll be writing to government to say that as a part of our wellbeing strategy, we expect fairer funding because this is so integral to our progressing our children.
I was going to add a B, which was that we write to the government, not necessarily in the eloquent words that you use, Councillor Lester, but that we write to the government and point out the fact that we're it's a double whammy, isn't it? Really, because our funding for education is not good, and our children, if they do manage to get a job, it's low paid, and it is for all people, and it is for their parents, which makes it even more difficult for them as a child. So if you could add that from Ben. You can use the eloquent words of Councillor Lester, or you can use your own.
Oh,
You can't say anything. Good idea. Right, we move on then to. Pardon?
Just to take it, just to get
A vote. A vote. Yeah. Can I have a proposer for that, please? Simon. Seconder. Jonathan. All those in favour? Pass. Thank you. Well, I go on to item 9, which is an interesting item because Zoe and I have had quite a long discussion about this outside of this meeting about what people class as gambling and what people just class as the flutter on the, you know, it's a and it's very interesting. Anyway, this is going to be going to be a presentation. I think you got that.
Yes, once we're ready. Yeah. Did Zoe want to introduce it?
Yeah, so I'll introduce.
And Claudia.
So you're right. We've had quite a few conversations about this, about gambling-related harms, and every local authority public health team has been tasked with doing some work around gambling-related harms, which doesn't sit usually in the traditional public health. So it's certainly a learning, steep learning curve for the team with very limited data in terms of what is the impact. But Claudia is our public health registrar who has been doing the work around this. So I'll hand you over to Claudia to present it, which also tackles the what is gambling, what's included and what isn't included.
Thank you, Claudia.
Thank you, Zoe. Hopefully my microphone's on. Perfect. Thank you. Can we go to the first slide, please? Brilliant. So, as just mentioned, I have included just a bit of an overview about what gambling is. I know most people around this table will already have a definition in their mind of what gambling is, but I think it's helpful just to refresh that. So this is the definition from the Gambling Act 2005. So statistically, most people around this room will at least know of somebody who participates in gambling. So it's estimated that 54% of adults in England participate in gambling every year. And actually we know that these figures are often quite significantly underreported. And as alluded to earlier, there are many types of gambling. So some is done online, and that's an increasing part of gambling. And that can be done either through websites, in apps, using people's phones. So that includes sports betting, online casinos, the National Lottery, and also in games. So people who play Xboxes and PlayStations may have heard of things like loot boxes and skin betting, which I had not, so I had to look up. But they are types of in-game kind of betting. There's also more traditional routes of gambling, so in-person gambling, which is things like a betting shop, casino, horse racing, and again the National Lottery. People go to shops to play. And although we know that a lot of people who gamble do not have gambling harms, there are significant harms related to gambling for some people, and they can be quite widespread. So these can include resources, so things like work and employment, money and debt, crime and housing, relationships, so impact upon their partners, families, even domestic violence. And actually there's an interesting statistic that for every person who experiences gambling harm, 6 to 10 people around them are directly affected by that. It also affects health, so physical, mental health and well-being. And in addition to that, there is a huge financial cost as well. So the estimated annual fiscal cost in Herefordshire is 2.2 million per year, with the majority of that on welfare, but also on health services. And linking to what Zoe alluded to earlier, mentioned earlier, about the key priorities, gambling harms actually does link into that as well. So looking at the best start to life, we know that young people are increasingly exposed to gambling adverts, and people who are exposed to those gambling adverts early are more likely to develop gambling-related harms. Also, that statistic I mentioned earlier of every one person who experiences gambling harms, 6 to 10 can be infected, and that includes families and young people. In addition, it does affect people's mental health as well, so that links to the better mental health priority, which I will come on to in a little bit in more detail. So the gambling levy has been introduced, and there are 3 arms to this. So that is research, prevention and treatment. And we are looking at possibly having some funding from this, so £33,000 of funding in the first year in Herefordshire. At the moment, I haven't had any further information on what this funding will look like or where it will go or how it will be delivered, but that is just the initial information that we've had, and that will be for the prevention side. Next slide, please. Thank you. So this slide just looks at the predictors of gambling participation and harm, and from a public health perspective, those who gamble most might be what you initially consider to be people at risk of gambling harm, but actually they're quite different demographics. So those who participate most in gambling are almost opposite demographics, in fact, to those who are experiencing the most gambling harms. There are a few overlaps, so the male sex is consistently reported as being at higher risk of both participation and gambling harms, although that gap is narrowing over time. When it comes to ethnicity, white British is reported most frequently. However, there is a caveat to that, which is quite important, is that people that are from BAME backgrounds are disproportionately affected by harm if they do gamble. So this list of demographics isn't complete. It's based on a national picture, and what we would like to find out is whether that does translate to locally in Herefordshire, and that's what we don't know for certain at the moment. There are other groups that are at increased risk, so veterans and students as well, although they don't appear most commonly on this list. Next slide, please. So looking at local insights, as we mentioned earlier, we don't have much local data at the moment, and the local data that we do have are in very small numbers, so aren't reliable enough to capture the full picture. So therefore, these graphs included are from OHID estimates. So the graph on the left, as you look at it, looks at the proportion of adults spending money on any gambling activity in the past 4 weeks, and Herefordshire is in yellow. And what's interesting is Herefordshire actually has a higher proportion than the West Midlands and the national average. However, the graph to the right looks at more of the gambling-related harms and risk of harms. So it uses a score called the Problem Gambling Severity Index, which is a validated screening tool to look at gambling harms. It's a questionnaire, and the scores are then compiled, and you are given a risk category based on those scores. So the dark blue, as you can see, is non-problem gamblers or non-gamblers. The orange is low-risk gamblers. The green, moderate-risk gamblers. And the light blue is considered problem gamblers. So although those percentages look actually smaller in Herefordshire, so we are possibly having people having less harm than the regional and the national average, it's still a significant number. So looking at those groups of the scores between 1 and 7, so the orange and green group, that actually equates to over 18,000 residents in Herefordshire. And looking at the highest group, which is that light blue group just at the end, it's 1.92%, but that also equates to over 3,000 residents in Herefordshire. And actually, if you look at NICE guidelines and other treatment guidelines, people who are scoring 8+ should be referred to gambling services. People who are scoring between 1 and 7, so they're considered at-risk gamblers, they may benefit or could benefit from gambling services. Next slide, please. Thank you. So looking at some data from the Gamble Aware Annual Treatment and Support Survey, which was carried out in 2024, people with those scores of at-risk, which were between 1 and 7, are less likely to access support in Herefordshire than nationally. Whereas people with the highest score of 8+, so considered problem gamblers, are actually more likely to access support in Herefordshire than nationally, which is interesting because we've taken this map from the Midlands Gambling Needs Assessment. It is a couple of years old, but I think it just provides a good overview and indication at the moment, just while we're in the information gathering stage. And it shows that actually Herefordshire doesn't have local provision at the moment. So this is something we want to find out further, whether this is the case, whether this is actually a gap or just a knowledge gap that we don't know about these services, both of which is important to know. So we are covered under the West Midlands Gambling Harm Clinic, which covers the region, but actually our closest service for that is in Stoke, which is a considerable distance for people to travel. We do have other services, Aquarius and GamCare, to name a couple, which are virtual and online services. But I just thought the map was quite a stark representation of, at the moment, where we're at with local provision. Next slide, please. Thank you. So as Zoe mentioned, we are conducting a gambling harms needs assessment at the moment. We're in the very early stages of that. But it will be the first gambling harms needs assessment for Herefordshire. And we hope that this will help us to identify vulnerable people who are already in contact with services. We know that actually, due to a lot of risk factors, a lot of people experiencing at-risk gambling or gambling harms are already within our services. We'd really like to strengthen local data and insights into gambling harm. We've already identified that at the moment we do not have as much data as we would like to. So that will definitely be a recommendation that we'll look at. We'd like to identify what services are available locally and what's missing, so tapping into the VCSE sector and other colleagues just to find out if we are missing key services. and to develop stronger partnership working across all organisations. As I mentioned earlier, a lot of people are already within our services who are experiencing gambling harms. So whether we can actually introduce our gambling awareness into those services to really identify people early and make every contact count is something that we definitely want to look at. And also just embedding gambling harms awareness wider, really, into all of our services, and just make it more visible, more aware for people. So that's most of my presentation, thank you. But we'd really appreciate any input and recommendations that you have on where to go with this needs assessment, what we should include, what we're missing, or you think is important. And also, whilst I have the opportunity, I'd really welcome the board's thoughts on how their organisations in this room could play a role in this and developing the gambling harms needs assessment. Thank you.
Before I call anybody, I think you said something right at the very beginning when you said what is gambling and what isn't gambling. And so I buy a lottery ticket once every 6 weeks, I think. And I'm doing it, I'd like to win some money, but I don't. But I'm doing it really for the fact that it funds sport and other things. I also buy, I think it's 3 tickets into OMAS to win a £4.5 million house, which I can then sell and buy something a little bit smaller. But and that usually goes to the Heart Foundation or St Albans. They're charitable things. So I would not consider, although I recognise that I'm paying money in to win something, you could take it down to the very low level of a school fete where you, or a raffle or anything like that. You're all gambling in order to pay some money out to win something, probably at a raffle that you're going to put in the next raffle. But the thing that the reason I had the particular conversation with Zoe, I've noticed over the last 6 months or more that there has been a real push to advertise gambling in the way of bingo to women. So there are, if you are particularly in the afternoons, put your feet up, have a cup of coffee, and play bingo. And I think not all of us, but most of us at some time, I did when my children were very young, used to go to a village hall where you got a card, and you were restricted really because you couldn't mark more than so many cards off at any one time. But that to me is shifting the idea of as you've got the English male who used to go into a betting shop, and there are now much less betting shops on the street because of the fact that it's online. And we still get it at places like football and places like that, and it's advertised all around the stadiums. But the fact that it is now infiltrated into female gambling, and the fact that it's not really gambling, it's just having a rest, having a cup of tea, and amusing yourself on your phone while you do your, and usually the first 3 goes are free, and then you're, I'm not saying you're hooked, but you could be. So this is why I discussed it with Zoe, because I thought we are moving in now into a territory of a completely different type of person who probably didn't gamble. It was normally men that gambled. It wasn't women that gambled, and now they've realised that it's a really easy option online, and it's a new way of getting more money in. So that's I've owned up to my gambling. Jonathan.
Yes, thank you. I just, in response, I think there's easy to make assumptions, but the assumption I would make is that older males are more likely to go into a gambling establishment, younger people are more likely to be gambling online. There's probably evidence that doesn't support that, but that's an assumption I would make. But so trying to regulate and police and ensure that gambling harm isn't perpetrated online is a really difficult scenario. I'm not sure what the answer is there, but I'm sure we'll put more thought into it. But it strikes me that identifying the victims of gambling is easier to do physically, and the people who probably know the best are the people in the gambling shops who serve their customers. So I'm wondering what the dynamic would be in reaching out to those companies to say, look, this is our initiative. We don't mind gambling taking place. You know, everyone, so long as they're doing it legally, has a right to do that. That's their right as a citizen of a country where gambling is legal, subject to the law. But they seem to be the key people who can observe who the people are who are most vulnerable. And I think that takes place in a physical environment in the shop. And so, I'm wondering what liaison we have with people who work in gambling shops. B, what liaison we have with the companies themselves and their own policies in their own shops. And C, what promotional information can we provide those shops to be on display, because they'll obviously want to display the latest way to gamble, and this is going to potentially win you this, that, and the other. But how much of their eye line is, well, hang on a minute, this might be a new game, but is gambling an issue for you? If so, please contact that number. So I think that's my thinking on the matter, but I'm not clear on. I mean, I've been in a betting shop once in my life, so and I won instantly, Chair. It was a tip from a horse racing, but going in there
From a
horse racing stables.
Oh,
but
right.
but what is on offer there to detract someone from? Hang on a minute, that's the latest offer game or whatever. But what's the advert saying? Hang on a minute, have you got a problem here? And do we know that?
Thank you, Councillor. So I suppose going back to Councillor Gandy's point initially about the National Lottery, so that is important because a lot of data actually separates the National Lottery from gambling as a whole. So although I mentioned earlier that 54% of people gamble in England, actually that is 40% if you don't include the National Lottery. So that is a big part of it. The other side of that is that actually, I said about males gambling more often, which most of the data does still consistently show, although that gap is narrowing. And like you said, the type of gambling is changing over time, with online becoming a lot more popular and actually a lot more targeted. So there are a lot of targeted adverts to certain groups, especially for different types of gambling adverts that they think would appeal to them more. We know that males generally do different types of gambling to females, but actually overall participating in national lotteries and participating in charity lotteries make up a significant proportion of that. They are the largest proportions. As you mentioned, Councillor, about the gambling shops themselves, we haven't had any contact yet with gambling shops. We are still at the very early stages. We have actually asked our intelligence team to map out those gambling establishments and those licensed premises around Herefordshire and overlay them onto a map of deprivation, because I think that's really important as well, because we know gambling is a commercial determinant of health and there are huge inequalities within that. But that's definitely something we would like to explore. There is legislation around gambling, but they are quite self-regulated. So that would be outside of our scope to change any legislation during this health needs assessment. But like you said, that might provide a good partnership and opportunity to find out locally the people who do gamble in-house or in person, whereas we might struggle to get some of that data about online, especially as most gambling occurs solitary, so it occurs on their own, and a lot of it is online now through phones and placing bets in sports shops.
Joanna?
Yeah, thank you. And obviously from a safeguarding perspective, it's an area of potential concern. Every day's a learning day, isn't it? So I thought the predictors of gambling was really interesting in terms of the way it's skewing towards a high gambling participation amongst a group you might not have expected. I've always understood that there might be a predisposition dependent on personality types. If somebody's got a bit more of an addictive personality, so I'd be interested in whether that's right or not. You're very welcome to be corrected if wrong. The other bit just of information is my understanding is that the government is proposing to introduce legislation to curb the amount of online gambling that can be done before somebody has to have a financial assessment, and they're wanting to bring it in. It was just recently in the paper. So I think it's over 25, so it starts at 5,000 in 24 hours, and they're going to reduce that over time with an age. So it might be worth just checking that out. I did read about that.
Thank you, Joanna.
As far as I'm aware, that some of the local voluntary organisations don't deal with gambling directly, but it's the mental health issues or debt advice or things that are associated with rather than directly. But I'm quite happy to work with you to reach out to the sector to get a clearer picture on that. So just get in touch, and we'll put out an ask to the voluntary sector to see how active they are in this space to get a clearer picture.
Hilary.
It's not so much a question as a comment. I'm sure people saw in the news this morning about tragic death of someone associated with gambling, and quite a strong pressure on certain bookmakers in order to kind of what are they doing, a bit to Councillor Lester's point about, you know, what are they actually doing in a proactive way to address it. So I think it's quite interesting that that's coming through, and probably linked as well to what Joanna said around the legislation. But it's definitely feels like it's something that's gaining some momentum.
Sorry.
I very much welcome the offer, because I think where this is going to be really sparse is in terms of any data. Councillor Lester's point around going into betting shops, but actually a landscape that's changed in terms of lots of that online betting's are very hidden and we don't see it. But certainly lots of our partners, including voluntary and community sector, will have a better idea of that and the impact on mental well-being as well. And then also, I think there's an opportunity through our Crisis Resilience Fund, so people that are coming forward in terms of needing that, you know, very quick response because of where they find themselves financially. There's an opportunity for us to have a better understanding of what's driving that financial crisis and whether some of that is linked to gambling. So whilst that's early days, I certainly see that that's an opportunity to feed that into the needs assessment as well. And certainly the needs assessment that Claudia's working on brings together all of that information in a way that we haven't had before, to tell us what the picture is and how we might compare with other areas, and where the gaps in terms of signposting and service provision is, and how we support people best.
Nigel.
Hi, yeah, no, I find this fascinating. I wonder whether it could be linked to some of our existing programs around health checks and things. We ask people about their tobacco consumption, we ask them about their alcohol consumption, and there are some brief biosocial questions that you can ask around gambling. And I just wondered whether we should be highlighting people who are at increased risk through that process, because we've got an existing program which also does outreach and targeted into some of our most vulnerable populations.
Yeah, it's a good idea. Okay.
Thank you, Nigel. Yeah, and that is really important, and that's kind of what I was alluding to when I said about making every contact count and seeing if we can incorporate that into services. Like you said, when people register with a GP, they're often asked about smoking or alcohol, but we don't yet ask about gambling routinely. Likewise with health checks. But actually, that is an area where that could be introduced and could identify people early and really aid that prevention.
Liz.
Thank you. this aspect is covered at secondary schools in their PHSE curriculum, the risks of gambling and so on. So again, if I can provide any link to talking to secondary head teachers about the quality of their curriculum and the impact of that, and link in with the schools and what they're doing, please
Good.
feel free.
Good. Sarah.
I mean, I think there's also something around both the council and the trust, the Wye Valley Trust, are big employers. So, and a lot of our staff actually live and work in Herefordshire. So there may be something that we can do across our organisations to, make sure that we're clear on the issues associated with gambling, but also to be more aware of it when we are carrying out sickness checks and things, to make sure from a health and wellbeing perspective that's not an issue for any of our staff.
Yeah. Anybody else? No. I think it's a very, very good report you've done, and I think from the feedback that you're going to have some work to do on top of this, but that's what you wanted. I mean, the idea is to highlight it, because I suspect the majority of people around the room would not have actually thought about it until we started to talk about, well, we talk about bingo, but that's where it comes from. So we'll move to the recommendations, which is the covering report recommends that the Health and Wellbeing Board is asked to note the contents of this briefing paper for information. And I think we could put one, and we'll seek, you put some wording, can't you, together? We'll seek some advice from voluntary sector, Wye Valley Trust, add it to the health checks. Yeah.
Yes, Chair. Certainly. Encourage partners to see what they can do within their own organisations, and perhaps if I could circulate Claudia's details to board members, then perhaps you can get in touch in due course.
That'd be fine. Thank you very much, Claudia. That's very, 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 very helpful. But I should continue to buy my lottery ticket and try and win my £4.5 million house in the Cotswolds.
Cornwall, no good.
4 will do. And actually, I prefer it to be by the sea with a swimming pool. But a bit cold, isn't it? But I'd sell it. So we move on to item 10, which is the Better Care Fund. And Hilary will introduce it, and I believe Marie Gallagher is online. Yes.
Thank you, Chair. So this report provides the end-of-year report on the 25-26 Better Care Fund. As you know, it was a £30 million fund in that year. The plan itself was met all the national conditions, which was to have a jointly agreed plan to implement the objectives of the Better Care Fund, to comply with grant and funding conditions, and to comply with oversight and support processes, all of which was met. Our plan was approved by NHS England, although we were required to complete a delivery plan focused on the achievement of national metrics. That was a local condition. I think overall the programme, as you'll see from the report, has delivered strong performance on emergency and permanent care admissions. So in terms of emergency admissions to hospital for people aged 65 and over, we achieved the target performance. But on permanent admissions to residential and nursing care, we significantly were under target, so outperformed where we expected to be. And I think that reflects our continued focus on supporting people to remain independent for longer. What we've seen overall is a progress in strengthening integration across health and social care partners and the work that we're doing together. But clearly the biggest pressures and the biggest challenge has been around hospital discharge performance, and those metrics remain below target, and we didn't achieve the targets that we'd set out. I think for all that, we have over that year and into this year developed a whole host of improved processes around discharge to assess, which supports that hospital discharge. improve multidisciplinary team working and stronger partnership governance. And clearly partners are reporting improved communication, better escalation and greater confidence in shared decision making. That doesn't get away from the fact that we overspent on the Better Care Fund last year, and that overspend needed to be picked up by the two partners in the fund. There is, as I say, much work that has gone on and continues in this current year. So the pressures have been particularly in discharge to assess services, but also in our DOLS and AMP services and in safeguarding. But overall, we have had a mixture of success and a mixture of challenge, and those challenges continue into the current year, which will be the subject of the next report. Very happy to answer any questions the board may have.
Well, I've got two questions really, which are pretty obvious. Why did we overspend on the dolls? And why did we overspend on safeguarding?
The main issues have been around workforce capacity, so we've had to employ agency staff, which has had an increased cost to that. And also there's been increased demand on those services, which has meant, again, we've had to respond to that, which has caused the overspend. They're not massive overspends, but they are still overspends, which we've had to manage.
Has anybody else got any questions? No? Did everybody read every page? I mean, to be serious, this is a really important document. I mean, I accept it's gone. I mean, it is what it is, but it's a report back. But it is a really important document because of the amount of money that's involved in this. And as you can see, for those of you who've not attended these meetings before, you can see what the money is spent on, and they are really important areas of the service. And I think, you know, we should really, although we now receive the reports after they've gone off, we mustn't ever forget the fact that they are really important reports. So I'll go back to the recommendation, find it. That the Better Care Fund 25-26 end of year report Appendix 1 submitted to NHS England be reviewed and approved retrospectively by the board. Do I get a proposer for that? And a seconder. And secondly, that the ongoing work to support integrated care, health and care provision that is funded by the BCF is noted by the board. Proposer, seconder. Yep. Everybody in agreement? Yep. Okay. We now move on to item 11, which is Herefordshires Better Care Plan 26-27. Again, introduced by Hilary, and Maria's on Teams. So I'll pass over you to Hilary.
Thank you, Chair. So the purpose of the report is for the board to approve the narrative plan and numerical template, which we've already had to submit to NHS England to meet national deadlines. The plan itself, and I'll echo what you said previously, it's a really important plan, is around supporting our strategic priorities to help people remain independent, strengthen home first and reablement, improve discharge and flow out of hospital, and reduce avoidable demand on hospital and long-term care services. The total financial allocation is just under 31.5 million. That's a increase of 584,000 on the previous year. I think it's important to note that that doesn't fully meet our inflationary and demand pressures. So the plan has had to include agreed mitigations to balance that. The whole risks around workforce capacity, care market availability, discharge demand, those remain. They managed through our established governance arrangements. I think it's worth pointing out, and we've had the Neighbourhood Health update earlier in the agenda, that this year's fund represents the first year of national reform of the Better Care Fund, which is placing greater emphasis on demonstrating impact through integrated neighbourhood-based delivery, strong alignment with that home first approach, and again improved reablement, as well as increased investment in adult social care. And that's part of ongoing reform of the Better Care Fund aligned to national neighbourhood health. We've structured the investment around 3 core work streams, so around discharge flow and system coordination, around intermediate integrated care, and around prevention, carers and community support. So what we're aiming to do is to pool resources at that kind of whole system pathways rather than fragmented service responses. For the current year, we have been required to set improvement goals against 2 headline metrics. That's around non-elective hospital admissions for people aged 65 and over, and the average length of discharge delay for all acute adult patients. I think it's, in summary, I think we have a strong plan, Chair, but I think those financial challenges remain. The demand, particularly in Herefordshire, is not getting any less, and whilst we're working hard, those challenges still remain in terms of the financial pressure and the fact that whilst we had some increase to the fund, it doesn't meet what we know in terms of inflationary and demand pressures. We will continue to work hard to manage and mitigate those financial challenges, but I think it's only fair that we make the board aware of that challenge. Very happy to answer any questions, Chair.
I think if people haven't read all of the report, the last paragraph on page 51 and the beginning of 52, page 52, which demonstrates the plans that are being put forward to changes to the service with a net impact of over £500,000 increase in expenditure, and you will see what items that are on there. I mean, ultimately, with almost everything we've discussed today, if we could prevent people getting, so my words to my parish councils regularly is, once you get past the age of 40, you've got to start preparing for your retirement and eventually your death. I don't necessarily like my reports, but it is absolutely true that if you prepare early and keep yourself fit and healthy, and all the other things that you need to do, and make sure that you've got, you're living, particularly when you're coming up to retirement, that if you're thinking of moving, move somewhere that is suitable for where you're likely to live at the end of your life, which might be a bungalow with no steps up it, perhaps a smaller garden, and all those things. And in my case, when I moved, a shop, public transport, a surgery, a village hall, a pub, the things that you need. And I'm not saying you need more, but you need as you get older. I've got in my own ward a significant number of elderly women who are living in very large properties on their own, who can't actually get down to stairs because their facilities are upstairs, but they don't want to move because they want to leave that property to their children. And it's a really, by the time they get to adult social care, they've got some very complex needs that we have to deal with that could have been dealt with a lot earlier and costs a lot less and been much better for the person concerned. That's me doing my teaching. Does anybody else have any questions? No? So we go back to the recommendations, which are the Herefordshire Better Care Fund 26-27 narrative plan, Appendix 1, and numerical template, Appendix 2, submitted to NHS England to be reviewed and retrospectively approved, and the ongoing programme to support integrated care, health and care provision that is funded by the BCF is noted by the board. Proposer? Seconder? Thank you. We move on to item 12, which we're nearly there now. Item 12 is the work programme. So this is an opportunity to consider any items for inclusion in the work programme for the board. The updated work programme has been circulated in the agenda, and in particular, board members are reminded about the board workshop, which is a private meeting for board members only, that's being held on Monday the 28th of September. And Joanna, would you like to just mention what you asked if we could add? You could add to that private meeting.
Yeah, thank you, Chair. So the Adult Safeguarding Board has commissioned a piece of work that our public health colleagues are leading on, looking at complex lives strategy. They're taking a very innovative approach to it in terms of looking at case studies, which they're hoping to draw from voluntary sector and others across the summer to help inform that strategy. And we're anticipating there'll be a first draft in September. So we thought it might be timely to think about how we could build that into the workshop as a first look potentially. Zoe doesn't know any of this, but otherwise we would need to programme it in to bring it back more formally at the appropriate time. Zoe, if that's better wording for you.
Zoe.
Yes, certainly the plan for the workshop is to look at what we've already got in place, and that would be something key that we've got in place in terms of hearing lived experience. So I'd very much welcome having that as part of the workshop, but alongside, you know, other mechanisms that we've got already in place, and take regard of that, and then as a board think about how do we hear that better through Health and Wellbeing Board, and how do we utilise it better. So yeah, I'd very much welcome that piece of work.
Absolutely fine. And if anybody else has got anything that they can want to contribute to that particular workshop, just to let us know if they think it's appropriate. The next board meeting is on Monday the 26th of October at 2 o'clock. And I'd like to thank you for your attendance today. And good night. I've got some minutes to sign.